Okay, so good afternoon, everybody. So we have a panel that has the potential to generate a lot of interesting conversation. So the title of our panel is Institutional Structures and Financing Models for Building Robust Primary Healthcare Systems. And when I read the title of this panel, I was wondering who wrote this title. It has so many different layers to it that it could potentially be a disaster or a very interesting conversation. And I'm going to do my best to make this into a very interesting conversation. But before we start in the panel, I should introduce our panelists. And these are three people that I have known for many years and learned a lot with, who I could say in many ways my public health career has sort of spanned. Let me first start with introducing Major General Professor Atul Kotwal. Dr. Kotwal is the Executive Director of the National Health Systems Resource Center, which is an important technical unit attached to the Ministry of Health. Dr. Kotwal is a medical professional, public health researcher, administrator, and he has made significant contributions to the field of public health for over 37 years. His areas of expertise include health systems, planning and implementation of healthcare policies, primary healthcare, urban health, epidemiology, health technology assessment, implementation research, and interdisciplinary research. We also have the pleasure of working closely with NHSRC and Dr. Kotwal on the IPSI project, and so it's a great pleasure to welcome you here, Dr. Kotwal. The next person that I'd like to introduce is Dr. Rajani, who's the Director Health at the India office of the Bill and Melinda Gates Foundation. I don't think Dr. Ved needs introduction to many of you, but I'll still go ahead. So Dr. Ved is a public health physician, technical advisor, and implementation specialist with nearly 30 years of experience working on community-based services, health services delivery, health system strengthening, and in scaling up. She has worked with national and state governments, research institutions, aid agencies, and grassroots community organizations. She used to be the executive director of NHSRC, and I've had the pleasure of knowing her and working with her since then, and now also through the IPSI project. So very warm welcome to you, Dr. Ved. Finally, I'd like to introduce Dr. Aarushi Bhatnagar. Aarushi and I go a long way back. I first met Aarushi when she came to PHFI. I think she had just finished her master's at that time. And we started working on human resources for health, something which I am glad to see she's continued even to this day. But she is an economist with the Health, Nutrition, Population Global Practice at the World Bank, and she's currently based in New Delhi. She joined the bank in 2018 when she's worked extensively on health service delivery, quality of care, and again with a particular focus on human resources for health. Prior to coming to the World Bank, Aarushi worked with Oxford Policy Management. She also worked with Johns Hopkins, the Public Health Foundation of India, where we first met, and she's continued her work in health system strengthening across several LMICs through these different jobs that she's had. She completed her PhD in health systems from Johns Hopkins, and she holds a degree in economics from University of Cambridge and Delhi University. Very warm welcome, Aarushi, and good to see you here. All right. So with that, we'll get on with the panel. If you don't mind, I'll stand here and ask the question that's somewhat easier for me. So if you look at the title of our panel, which is Institutional Structures and Financing Models for Building Robust Primary Healthcare Systems, I wanted to start with the institutional structures part. And if we think of health systems governance as referring to the processes, structures, and institutions that are in place to oversee and manage a country's healthcare system, my first question would be to Dr. Kotwal, which is, many would argue that the current institutional arrangements that we have in the health sector governance, which relates to government, needs reform and needs strengthening. And there's an NHSRC report that also talks about this. So I was wondering if you could tell us a bit more about that, about what sort of strengthening do you see governance from the perspective of government that is necessary?
Thank you, Dr. Krishna, and thanks to the organizers and thanks for inviting me. I think I am the odd man out here who has no connection with the Johns Hopkins till now, except for attending the symposia off and on. And but anyway, thanks for the invitation, and great to be amongst people who are trying to in their own way making efforts and serious efforts to strengthen the comprehensive primary health care. So the question Krishna posed to me was that the governance structures and all, and what kind of strengthening need. So we already have as such a structure, if you see, which you all are aware. I'm just quickly kind of recapping it. That is the central government with its own kind of think tank and supporting institutions, also NHSRC being one of those. And then we had a state level also, and same at district and block level, and at the health and wellness center level also we are trying to create such kind of structure, and which is already coming into place. So the capacity building of all these people as such, that is now, initially it was in fits and starts as such in some kind of courses for the for those the administrators coming to the extension ministry from the undersecretary level to the secretary level, and also various other commissioners and all of the medical stream of the BSPH. Now under Mission Karam Yogi, there is a defined process to it. The courses and the topics and all everything has been finalized in an agitated manner over the last 3 years, and those have already got to start as such. So that kind of capacity building efforts are there to improve the governance. And the same thing applies to those working at the state and district level also. For implementing all this so that the governance improves as such, we already are now linking with the community. The governance only to be done by the healthcare workers. So we have Jan Arogya Samiti, and we are trying to strengthen the wellness and nutrition community. And in the other areas, so that's the kind of structure which is there. And I don't think we need more people as such for the governance mechanism. It's more of capacity building. And similarly, just like NHSRC, 15 states have already created state health resource centers where we have convinced the government to increase the funding for those, and that is now already fructified. About 6 more states are now planning to create SSRC, out of which 3 are almost their terms of reference and everything has been approved. So very soon we have more than 20 states, and 15 are already functioning in SSRC, and we are creating innovation hubs also within those to give more input to the governance as such, to learn from the practices and best practices and innovations on the ground, which improve their capacities as such. And again, to improve governance further, the Indian public health standards, which are there to as yardsticks for everyone to measure, with dedicated kind of dashboards and all, that everyone at all level should be able to see at what level I am standing today, and what are the areas which are weak. And management cadre, that the cadre is again important, because that will again, we are thinking of, will improve the governance as such. One is the public health cadre, the health management cadre. Currently, everyone, we have contractual positions. We take pride in creating almost 4.5 lakh odd posts under NRHM, now NHM as such, but they are all contractual, and without any defined career structure. And these are the most important people as state nodal and district nodal and even block level officers, and similarly at the urban areas. So these, when they have defined cadres and all, obviously they are attracting them to these services and retaining them for the retention as such will improve. So these are the few initiatives which are being taken, and hopefully with that we will see our governance mechanism strengthened as such for implementation of not only comprehensive primary health care, but also assured linkages with the other services, strengthening of the secondary care also at the CSC district. I'll stop it.
I think my next question will be to Dr. Ved. Dr. Kotwal talked about these community committees like the JAS and so forth. You've of course been very closely associated with the ASHA program, and you have also published on that. Could you tell us, in your opinion, what has been the contribution of these sort of committees like the JAS, the Jan Arogya Samiti. In Meghalaya now they have the village health committees. What has been the contribution to the delivery of, say, primary healthcare services? And also, in what ways do you feel that these committees, which represent a governance institution where communities can participate in, how can they perhaps be strengthened further?
Thank you, Krishna. So, yeah, I mean, you asked me for a very specific example of an institutional structure at the community level in your bigger reflection about institutions. So, I think India, of course, famous for decentralization and policy, less so in implementation, at least across many states. And under the National Rural Health Mission, which goes back almost 18 years now, and I'd like to start from there, is we created the Village Health Sanitation Nutrition Committees in rural areas and a counterpart in urban areas called the Mahila Arogya Samitis. The Jan Arogya Samitis are fairly recent, only after the conversion to the now Ayushman Arogya Mandirs. But there were also hospital committees called Rogi Kalyan Samitis. And the vision at that time was that the ASHA, who was a community health worker, would be embedded within these community institutions, therefore making her accountable to be the link with the health system, but making her accountable to the community and to these committees. Now, as it happened, apart from maybe Orissa and Tamil Nadu and Kerala, in most states, the VHSNCs had variable functionality. Of the Mahila Arogya Samitis, perhaps there are only two states, Telangana and Orissa, where there was a lot of attention paid to building the capacity of the members of the Mahila Arogya Samiti, who were only women. And in the other states, the ability of these collectives, even though in design, they were all given untied funds, they were given the mandate to be able to actually hold the system to account. When they were facilitated by civil society organizations, which is actually an important part of strengthening institutional structures at the community level, is facilitation by some kind of organization. It could be an NGO, another civil society group, a technical assistance agency. There we actually saw VHSNCs flourish and do well and hold the system accountable for some of the services. So we also had a process called the community monitoring process, which I think has all but died out now. Went to great scale in Maharashtra, across I think over 5,000 villages if I'm not mistaken. But there, NGOs worked very closely with the VHSNCs and built their capacity to actually hold the system accountable, particularly where rights and entitlements were concerned. So the potential of community institutions to be able to hold the system accountable and improve population health outcomes is very, very high. However, the kind of nurturing it needs, the kind of funding it requires is not trivial. And I think that's the challenge that happened in states that didn't do so well. So I would, and also I think that it was, if I may say so, and I don't mean this facetiously at all, training 1 million ASHAs was easier than training the 12 million members of the VHSNC, because that's how the numbers translated, right? And so the ASHAs were never able to be integral to the VHSNC, although again there are exceptions. This is India. For every one thing that I state, I can point you out to 3 more exceptions. But the Mitanins in Chhattisgarh were an active part of the VHSNCs in that state. The ASHAs play an active role in the Kerala VHSNCs, for instance. But that's facilitated by state and also where the local government was stronger. I think that's also a very important factor in creating these community level health collectives, is a strong local government and very strongly financially decentralized. I'll stop here.
Okay. Maybe we'll go one round and then I'll switch gears a bit now, because a part of our title also talks about financing. And so, Aarushi, you obviously worked a lot in healthcare financing. And as all of us here know, government spending in India is among the lower ones globally, and that's also true for PHC financing. And yet, so there's a demand for increasing financing for health and also for primary healthcare. But given a country which has fiscal constraints, and most countries do, but in India's context, how do you see that the government can come to grips with this issue and increase financing for PHC?
Thank you, Krishna. That's not an easy question at all. But thank you for, firstly, thank you for inviting me here. I think in the broader global context, financing for primary healthcare has received more attention in the last decade. I think COVID was a reminder for everybody that primary healthcare plays a critical role that ought to be strengthened even further for emerging challenges that are likely to come our way. Having said that, I think the financing mechanisms for PHC have always been complicated. There is less incentive for the private sector to be a part of primary healthcare, so the financing largely relies on government spending or private out-of-pocket expenditure, which is actually unacceptable in many contexts, including ours. It's almost 50%, with of course a lot of variation across different states. So I think in that context, of course, the solutions, the easy solutions one thinks is to increase the financing envelope. But that's actually not easy at all. It's, given increasing the budgetary allocations are also tied to an overall economic growth outlook, there are complications, and especially given the global connectivity of our economies these days, there are fluctuations which one can't sort of deal with. Within the health sector, there has been an effort to increase financing through taxation, especially taxation of alcohol or tobacco products, and more recently there is a lot of conversation around increasing taxation for sugary sweetened beverages. I think there are examples from other countries, other upper middle income countries in fact, which have tried these taxation mechanisms. Again, they are not easy. The political economy around these changes in taxation regimes are complicated, but there are examples which could be used in the Indian context. India itself has taxation on alcohol and tobacco, and different states have different taxation policies around that. But I think there is scope for one to think about how that policy tool could be leveraged more. But I think really in the Indian context, what may be the solution, or what may be the key here, is spending better, not necessarily trying to figure out how to spend more. I think this does require improving the public financial management systems, and in the recent years there has been a lot of effort from both the central government but also state government, and given the federal structure in India, the liaison between the central and state government financing mechanisms, especially the public financial management mechanisms, have improved. These are the budgetary planning. Dr. Kumar, I'm sitting between both people who've gone through several years of planning for the National Health Mission, and these are really robust mechanisms that happen over entire, each year takes several months to plan for. I think similarly there are also ways to improve budget execution, and I think there is now effort to link execution to output or results-based approaches. So there is that deviation from input-based financing, which again is a marker of developing a more robust public financial management system. I can come back to this later because I think we'll come to this conversation, but there is, and this is also the recent Lancet Global Commission on Health Financing for Primary Healthcare, that is advocating for blended financing with capitation at its core. And so this again does involve, if one has to think about financing mechanisms of that nature, it does mean improving financing, improving the spending of the current financing. But maybe I can come back to that later.
So I wanted to keep on the topic of financing, but take it to a broader perspective, and I'm asking this to all three of our panelists. We have states in India like Kerala, I would say Tamil Nadu too, that in terms of the big picture don't spend so much on health per capita, and yet have achieved very remarkable health outcomes. Kerala has of course been very well written up, Tamil Nadu too, I would say. And so while there's this demand for more financing for health, with the understanding that more financing will improve health, you have these states that seem to be doing a lot more with a lot less, right, in a relative way. So so I wanted to ask you whether is it spending better, is it doing things better, and what lessons might these states have for other states in this country? So maybe we could start with you, Rajani, and
Actually, might I suggest to start with Aarushi?
okay.
Okay.
Okay, all right, fair enough.
Okay, thank you. I can speak, I think, more confidently about Tamil Nadu. I know that better than I know the context of Kerala and the other states. Well, when you say that they're spending less, I'm not sure to what extent that's also true. Like Tamil Nadu, on average, if you look at all the states in India, does spend a larger proportion of its government expenditure on health. So there is a little bit of spending more, at least in the case of that particular state. And there are, I think, also mechanisms that make it spend better. And these are historically stronger public financial management systems and so on. But since I'm speaking first, and I think Rajani may want to speak about these, but I think in the case of Tamil Nadu, there is a very strong link to stronger governance mechanisms as well. I think Tamil Nadu does have, for example, just to give you some concrete examples, it has the Tamil Nadu Medical Service Corporation that does the procurement for drugs and supplies, and this is a very robust institution that was, which has in many ways a good example, and many other states have actually tried to also learn from the experience of TNMSC, and through its in sort of functioning in a transparent manner, in getting competitive, prices for their medication and other supplies that they're procuring, they are ensuring equity in service delivery, and in some sense also reducing out-of-pocket expenditure, especially on drugs. And we know that that's actually the largest proportion of out-of-pocket expenditure in most countries, but definitely in India. So I think there are certain governance mechanisms or strong institutional structures at least in Tamil Nadu, that also allow it to do more for its health sector. Tamil Nadu also has a standalone Directorate of Public Health. It's been there for 101 years now. So they prioritized primary health care as early as over 100 years ago, and that also allows them to design the health service delivery in a manner where primary health care is prioritized.
Thank you. So taking off from where Aarushi left, I think Tamil Nadu classic combination of somewhat adequate financing, I would say, but coupled with the institutional structures that they've created that enables them to do better than the other states. And even when I say enables them to do better, remember, selective primary health care is what Tamil Nadu has been very good at. Now faced with this onslaught of NCDs, they are struggling also a bit, but that we'll come to later. At least for the last several years for RCH, they've managed pretty well. I think that's a combination of multiple factors. I think the first one is they make sure that the personnel who are in their institutional structures, be it the directorate, be it the State Institute of Health and Family Welfare, which I think is called the Institute of Public Health, be it their medical schools, both individual competencies and collective capabilities are harnessed for public health care. So I think Tamil Nadu's made that very, very clear, and they've done it very well. They've also, so all of their institutions are rooted within government. So they've got a power and a position that's been given to them by administration. But then they evolve and develop their own internal organizational processes, which directorates in many other states haven't been able to do, and that actually distinguishes them from a directorate in, let's say, UP or Bihar or Madhya Pradesh. So I think the combination of financing and institutional, and I think the third thing they do very, very well is the use of data. Their reviews, their supervisory systems are really second to none. I don't have a sense that any other state, including Kerala, does it as well as Tamil Nadu. Their supportive supervisory and review mechanisms using the data has actually made them, yes, of course, they did it for immunization, they did it for maternal deaths and institutional deliveries, but they managed to hone that to a significant level where they could now, well, I hope, move it to NCDs and other areas. So I think that combination, and I know that all of this should be able to help them at the district institutional structures to give them autonomy. They do, their district institutional structures also have a lot of autonomy. But being able to do responsive financial allocations, which really is going to be very significant for primary health care, they managed to do it brilliantly well in terms of supplies, medicines and diagnostics, because they've got such a good institutions for medical supplies. And therefore that is very responsive to services. Their finances may not quite be that responsive, but this is an example. And so Tamil Nadu has examples across the board, which I'm sure they will be able to bring together to move on to robust comprehensive primary health care. So it's a combination of both.
Okay.
Sure, absolutely.
So just few some additions to what Aarushi said earlier. I'll start from the national level. The national health accounts of 1920 clearly show that from 1.1% we have achieved 1.35% of GDP. Our target is 2.5% of GDP for the government health expenditure. 2021 and 21-22 national health accounts are ready. We have prepared it. I can't share the exact figure with you because not been approved by the HFM as yet. But 21-22, with all the infusion of funds from the PM Abhim, PMJ fund utilization over the last 3 years, and Finance Commission tight grants of 60,000 odd crores, 70,000 odd crores, 60,000 PM Abhim. The government, this thing it is touching almost 2 now, but I can't share the exact figure with you. So that's a tremendous success which is there. Secondly, primary health care expenditure, target is 66% of the government health expenditure, GHE, on the primary health care as such. From 51% in 13-14, we have reached 57% in 19-20. So that's a tremendous leap within 7 years, 7% increase towards the primary health care. The other accounts also show the similar kind of direction as such, and this coupled with the PMJ is now creating we are moving towards the universal health coverage as such. Of course, we got a lot of work to do, and overall from 2.5 we have to reach up to 4 or 4.5. But this is linked with out-of-pocket expenditure. In 13-14 it was 65% of the total health expenditures were out-of-pocket expenditure. In 19-20 it is 47%, and subsequently it is touching almost 40 now. So but official figures till 19-20 is 47%. That's again a huge success, and that's because the government health expenditure is increasing. And if you see the graphs, as the GHE is increasing, so that out-of-pocket expenditure is reducing as such. And it has happened because of the out-of-pocket expenditure, as you all know, the drugs, diagnostics, transport, and the inpatient expenditure. And that all are being taken care of under various schemes, free drugs and free diagnostics, and the ambulance services strengthening, and with the assured kind of services under PMJ of 5 lakh with the last 3 years, tremendous increase every year of increase in funding is over there, and strengthening of the CHC and district hospital also has reduced that expenditure. Coming to your statement, which Aarushi also has mentioned now, I got the actual figures, actually that's what I wrote. In 1920, Kerala spent 2590 and Tamil Nadu spent 2039 per capita, which is higher than the national average of 2014. So they are spending more as such, not lesser. But yes, Tamil Nadu model, as both my co-panelists mentioned, is much more efficient. But I would corroborate Dr. Rajani's apprehension that for the now onslaught of NCDs, even though with their MTM scheme, which is doing very well, which is one of the best practices which we have shared with all the other states also, their TNMSCs, and now we just recently did a quick review, the outages of drugs have started taking place, which is first time in Tamil Nadu actually in the last few years. But again, knowing for sure that with their institutional structures, and that's why the public health cadre, which Dr. Aarushi mentioned, we created this public health management cadre, which is for the entire country, that every state must have a public health cadre, with the feeder being medical officer and public health specialist in that. Health management cadre separately with the medicos or majority non-medicos, with 35% reserved for almost 35-40% depending on the state size, to the those dealing with the financial mechanism, this thing, and those with human resources background and all, to strengthen the entire system. And we are also now trying to create a nursing cadre as such, so that the CHOs, which are new MLHPs now at the sub-center level, they also get an assured career progression as part of the nursing cadre, to strengthen the governance structure, and also to, as very rightly mentioned by Like we said, the 55 lakh for creating new, building for public people, PHC. I'll just give you one example. Some states said that it is not that what we actually need, because the land is free. We can do it with less. We said, okay, we can reappropriate. Some states said we need almost 1.5 times or maybe twice. So that's where the efficient effective use comes up. And we know what are the various reasons. I'm not going into details of that. You all know. So it's those how to plug those gaps and for the money going out. That effective and efficient use is, I think, more important now. Funding is first time, I think, and we can't increase funding so much more as such because of the absorptive capacities of the states. Out of the 4,000 crore given PM Beam last year, only 1,000 crores was utilized, because the effective capacities also have to match the funding. So the gradual increase in funding as is taking place, that's the policy prescription, which with of course some kind of governance, strengthening governance more for effective and efficient use. And PFMS is another one important initiative. Each and every penny is being now tracked as such. When did it leave the central pool? When it left the central pool to go to the NHM society, or now with under the Finance Commission grants, the PRIs and ULBs. Once they get, everyone said they are not strengthened enough to spend. So that's why money is not being spent by many of them, except for a few states like Kerala and even Nagaland and all. Schedule 6 as it is doesn't have all the powers are as it is with the those
I'm sure lots of you have questions. I have a lot of
get your question correctly as such. Pardon me, I'll just try to repeat it, rephrase rather. SHSRC is not in UP right now, it's there in Chhattisgarh as such. Yeah. Yeah. UP has been one of those in and out as such. It's but although Dr. Rajani will, I think, talk more about it, I say the BMGF is there in UP in the last 17, 18 years. That's why probably SHSRCs are not coming up in these two states. So that's where now BMGF, I think, probably needs to explain this, and because we keep on discussing with them, they also discuss with us, then subsequently there's a lull period after that. Last 3 years of my tenure at ED, I have seen this happening on many occasions. So, but we feel SHSRC should be there, and we need to embed the innovation hub also within that SHSRC only, to have a kind of supporting mechanism for the state, for the governance mechanism, and even for implementation. I hope I have answered your question correctly, or is something other part also?
One part I wanted to ask that state like Chhattisgarh, which was made much more later, and then SHRC there has been doing quite a good job in different area. Yeah. But now UP being established well before, and not a state, not a partners involved, but still the capacity building and that component of institutional strengthening is not.
Yeah, so that it's a very difficult question to answer as such, and but I have already answered partially as such, that the development partners are there since last 17-18 years, and somehow I think the mechanism in both states are different. Chhattisgarh, as it is a smaller state, and that's the the initial ashas came from there only. So the community processes are stronger, much stronger in Chhattisgarh. In UP, the urban local body has only got one member. Are you aware of that? So urban local body is not even enough to even devolve the powers as such on the health part as such. So And Chhattisgarh as such, I must share with you a tremendous success in last few years. They were the first ones to create this, of course we helped them with the development partners as such, for creating the block public health units and integrated district public health labs. And community process as it is, they are strong. Now with the PVTG scheme, with the tribals coming under the ambit, in the radar as such, and a lot of efforts being taken now to get them into mainstream. And also the sickle cell anemia, sickle cell mission as it is not only for sickle cell, it also is a opportunity to create awareness about other diseases also, and it's a contact point as such to begin with. So that's why Chhattisgarh I think will definitely be always better than UP, even when UP starts. UP's, but let me share, in last 1.5 years there's a lot of positives coming out from UP. One is creation of more medical colleges which they are doing. Secondly, even nursing and paramedical, the allied health, that's what also they are planning. Their spending efficiency has also increased in the last 1.5 years. I would ascribe it to, I think, probably the leadership. That's one of the major things which I have seen in last 3 years and saw the change immediately. I think probably can share more, because probably ground experience in UP and Bihar are more with her. And of course, I have served in Bihar earlier, and in this tenure I have been to UP and Bihar. It will take a lot of time. In Bihar, there are places in aspirational blocks, on the aspirational blocks, where the sub-center doesn't have a building, even though they're not even rented. It sits in one school one day and in the other school another day, and there's one CHO for 5-6 this thing even now. So we need to do a lot of work on that, and I think probably, and that's why the TFR here and all the other indicators also. And there are several states which have achieved the SDG levels, but these two states we need to work more. And probably we can discuss the strategies for that. That would be more important.
So Krishna, I'm going to respond to.
Okay.
And I'm feeling very, very schizophrenic just now, because for 12 years I was in NHSRC, and for the last 2 years I'm at the Gates Foundation. And when I was in NHSRC, our constant question used to be, what is the Gates Foundation doing in UP and Bihar? And then I'm in the Gates Foundation and I ask myself and my colleagues the same question every day. But seriously, in both states, we have tried very hard to get the states to say, set up your own SHSRC, and the functions of what the technical support units, and some of you are partners of those technical support units, all of those functions need to be transitioned within the state health system resource centers. Needless to say, the foundation is a small player in these two large states. They may be a big player, but in the sense of a state budget, the state has far more money than the foundation will ever put in. And they take the call. And there has been, UP, always the pushback has been, we have SIFSA. Those of you who don't know, SIFSA was set up by USAID at the time when I worked in USAID. It's called the State Innovations Family Planning Services Agency. It was set up about 92 or 93. When aid left, a decade later, they gave it a corpus of 100 crore rupees. And SIFSA does have a lot of money, but for some reason, it was never able to be transformed into a state health systems resource center. So there is this constant struggle. This is top of my list. Every time I go to the state and speak to the leadership and say, you do need a state health resource center. But I think because they have the TSU and all of its partners, they don't see the immediate need. So I dare say when we step out of the state, is when they will be. But it shouldn't be like that. It should happen today when all of the functions can gradually be transitioned into a state health system resource center. So there is that challenge in both states. But I think to your question, and because I know the Chhattisgarh SHRC very well, I was part of its evaluation in 2005, and then have been on the board for many years after that. I think this is where many of you are work, the culture, the workflow, we created ourselves and made HSRC. So I think there's a lot that goes into not just creating. Look at a number of other HSRCs. Or for instance, Maharaj, they're all good, but they have smaller roles. It's not a wide part of the government.
I'll just add on to, sorry, but I inherited an excellent cognitive from my professor, and I must share with you that such and strength at that time knew that today's sessions so the good work, which was excellent work was done, I could contribute more and came out to be excellent over there. And we have double-story building under the view of the most welcome to visit tomorrow if you have time. And now the large basement where 20 people are sitting has been, we have taken over from NHS. We are expanding into NHS gradually. So probably we'll have more rooms and all because I'm getting 25 more vacancies in this year. So I have to make room for those people also which I don't have. I need more space. And that's why SHSRC is getting 1 CR as per NHS document. Now each major state will get 2.5, so they can get good quality HR and ED. And there's a funding under IRHSS, implementation services. So a lot of their own funds can be saved because we will fund them for those research studies as such. Once we approve of PIP, beyond PIP also we can fund under IRHSS. And we are very shortly going to have a workshop with SHSRC. We are also going to launch the SHSRC operational guidelines in Bangalore, which we request you to come over that day because that's what was started that time.
I can attest to the high quality staff that NHRC has, both from my own team and from others. So I think great work in nurturing these people. Let's get okay. Yeah, let's take a few. We got 2-3 more questions. So
I have a more of a fundamental question. This is regarding the when we look at funds across NHN, there is there also some level of earmarking that prevents the state from utilizing the funds, and is there more value in giving states some more of the funds? It's more of a fundamental question. And is there value in revising the district health action plan so that the planning can be done from a more bottom-up approach, vis-a-vis top-down approach in looking at the PS and the
So I'll take a second question first because when the NRHM started, there is a provision of integrated district health action plan. And so initially all those plans used to come here and get evaluated in the Ministry of Health. So it was not a bottom-up, it was a top-down approach again. So that's why subsequently states were given this choice. So as per the mandate, they are supposed to be village health action plan, block and district, and state is supposed to collate all that and then come through the PAP process. And in the NPCC, the PAPs are analyzed as such, and the NPCC with that discussion and all, it is finalized and record of discussions and subsequently released. So that's the process being followed. So it is a very bottom-up approach. State has got the full flexibility, and now wherever the community processes are getting stronger, the village plans are being made. In fact, I don't know if you have seen recently a few photographs and all, we can share with you subsequently. There's a drawing on the road or some floor on some building where village health action plan is being made and written and all, and it is happening now. And especially now with once 90% JARs have been made in more than 13 states, and several others are between 70 to 90%. So once these become fully functional and effective, I think we'll see more of these. The first one, fundamental question, yes. As I mentioned earlier, it's not that we keep giving more funds state, it's the absorptive capacities of states. I give you just one example. Out of 4,000 odd crore, only 1,000 was utilized. So the states had that funds. So it's the absorptive capacities, and it also the gradual increase as per the schemes is I think what is the way. And states are spending more in overall, even though it's 60-40 and 90-10 scheme of the CSS components, and Government of India spends on CS components also, but on CS also, but then overall it is 35-36% by central government, rest by state governments, combined as such. So they are spending because they have their own schemes also.
You know, it's a big regret to me at least that the original vision of NRHM was that every district would have its own plan and the state would take it all into consideration. What happened actually was they lumped everything, got one sum of money and then they but I think that's still something that's worth doing because I feel that there are two things that will happen because they have to take a district plan is that the data quality will improve because unless they look at their data they will not know how to plan and HMIS data as we all know is very variable and I think forcing persuading states, coaxing them to do a district health plan will improve the quality of our data. It will also help understand how do you do differential financial allocation. We know there are many facilities that have 10 OPDs, some have 200 OPDs, some have high load delivery, everybody gets the same amount. That shouldn't be the case. It has to be responsive financial allocation. And that's why a district institutional structure is really so critical. And that's weak in many states. And and they just have had so much to do over time that 20 functions then became almost 50 days. But having a very strong district health action plan is critical. And NHM does afford that flexibility. I think it's a matter of both capacity and willingness to be able to do that.
Okay. Thank you for the interesting discussion. So I just wanted to explore, like, a lot of our public health infrastructure, especially diagnostic or say, dental OPD, sometimes, remain underutilized. So especially tier 2, tier 3 cities where, we are looking at, mega cities, we are planning smart cities where a lot of these health infrastructure is upgraded. So are we looking at like even private physician, taking over these, utilizing these infrastructure and paying back to the government revenue? Who's your person, sir? Which panel? All of them? Yeah. Aarushi, would you like to answer?
I can, I don't know whether that's happening in India and my colleagues here may be able to give examples, but this is a model that's used in several other countries as well, and especially during the COVID-19 pandemic was actually a mechanism adopted by many upper middle income countries. I know Malaysia well, and I can give you an example of that this was something that we actually started doing because private facilities were closed during the pandemic. All the patient flow was coming to the public facilities which didn't have adequate staff, and so they rerouted the health workforce in a manner that they were utilizing facilities that existed but with the support of private sector employees. So I know that this is, and I think there are other examples as well of this. Whether it's something that's been envisaged here, I'm not sure.
So, I think our aim should be that these facilities that the government has paid in public health facilities, they should be utilized, number one. And we are going now with a time to care approach, not only population approach. There's a new mantra and we are working towards that. And with 30 minutes time to care approach, should be there. And if you see the NHS 4 and 5 data, there's an increasing number of people are using the public health facilities and reduce the expenditure by using public health facilities because of free drugs and transport and stuff. So, but yes, having said that, there are provisions of contracting in and contracting accountability. And these are local functions as such given to the state. And now under the 15 Finance Commission plan subsequently being utilized by DRS and ULBs from next finance commission onward, even at that level also it can be done. So the options are there. And but let me now digress a little bit from what you asked, since most of you are researchers and working on community primary health care also. Dr. Aarushi mentioned about capitation and all this. Comprehensive primary health care, PPP models. I don't have time. So we did an analysis of these models from NRHM onward from 2005. And I were interested when I joined. First thing I asked my CFP to do it, because I was in planning committee, and when we made the document of public-private partnership 2007-8, and that time I had a long discussion with Dr. Montek Singh Ahluwalia, and a lot of words like regulation and the meetings and the contingency plans, how it could be gained by any one of the agencies and how those contingencies to be used. Those were deleted from the final document because the government had its own reservations, whatever. But we did this review, it is available on our website. All those PPP under primary healthcare have not succeeded. There are very few successes, and most of them succeeded at the beginning. The moment the administrators or initial team changed, they nosedived. Whereas in secondary and tertiary, they've done PPP model, they've done much better as compared to primary. So probably we need to look at now, because the private sector is not that interested in preventive and promotive. These are public goods without any kind of benefit as such. They are looking more at curative and diagnostic. So there are several states who were into, like I'll give you an example of Assam. Assam, what we have been talking to states is that all high volume, low cost tests should be done in-house. Now with Finance Commission grant for diagnostics, there is enough funding. There is no dearth of funds for diagnostics. And low volume, high cost should be in PPP board. And also with the BPHUs and IDPHL coming up, with the sample transport system from the sub-center and Ayushman Arogya Mandir, I think this should be all can be done in-house. And we have given a mandate for minimum number of drugs as well as diagnostics at each level, which I think we all are aware. So Assam has shifted from PPP board to in-house. Himachal Secretary was here in NHRC today, and they are now taking a decision. They had come for final meeting with us and all, and they are shifting from private to this system, what we have said, hybrid system. So states are realizing the importance that they are just giving away money to private players for diagnostics, and even for drugs and all also they're creating TNMSC like models for improved, rather than purchasing at the smaller scale from private providers. TMSC will also purchase from private only, but economies of scale and with the kind of supply chain as such to ensure that drugs are available. So that is so we need to relook, all of you. I think we can go on ground and see what kind of PPP models are required for CPHC. Limited ones, but again with the benefit to the public and also to the exchequer also, of not just not at the cost of strengthening our health system for later on years also.
More questions, or should we stop? Yeah? So, all right. So thank you so much. And